Let me start by quickly telling you about RSBY. So RSBY is a program that was begun in 2008, intended to cover BPL populations in certain groups based upon their occupation. So for example, railway porters and the like. So it covered, its goal was to cover about 280 million people, roughly speaking, and it covered about 170 million people in the end. Although estimates vary. Its coverage, that was the eligibility, but the coverage of the program was to provide BPL families with 30,000 rupees worth of annual coverage for tertiary care expenses. And this would cover about 5 members of any given household. And so this is a 30,000 allocated across those 5 individuals. You could go get care, and this is secondary care, not tertiary care, so this is a contrast with Arogeshwari. It covered secondary hospital care at any impaneled hospital. And those impaneled hospitals varied across states. There was a small premium. It's really functionally a free program, but you had to pay 30 rupees in order to get a smart card. That smart card made you eligible for getting health care at these impaneled hospitals. However, like Arogeshwari, there's no deductible, there's no copay, which is an important distinction between the sorts of insurance programs we see, say, in India and the ones that people talk about in places like the United States. This is a program that was run because there was a smart card. It was a cashless scheme. That was a very important measure to make it function well. It was administered at the state level, even though the program was set forth at the federal level, and 75% of the funding came from the federal level, the central government. It was administered by states. So there's variation across states in how it was administered and how well it performed. An important feature of the program was what the government did is held auctions, basically tenders, at the district level and asked insurance companies to bid on who would provide the benefits that would be provided by the scheme at lowest cost. So there were these tenders. You would select an insurance company for each district, and that insurance company would, for the premium period, say a year, provide the coverage that I talked about. And that's important because even though it's federally funded, the federal government and the state governments paid for premiums, but it's private insurance companies that provided the insurance. And there's a reason for that. Private insurance companies have some experience in providing health insurance, even though it's not as extensive insurance as you would, or history as you would see, say, in a place like the United States. Okay, so that was the nature of the scheme. Back in 2003, so about 5 years after the scheme started, we worked with the state of Karnataka to run a large-scale randomized controlled trial involving about 55,000 individuals, 11,000 families, in 2 districts of the state. So we looked at Mysore, which was in the south of the state, and we looked in Gulbarga, which is in the north of the state. And we did an RCT where we assigned people to 4 different groups. And before I tell you what those 4 groups are, it's important for me to tell you a little bit about the eligibility. One of the reasons we did the higher return. And so what we observed in the data is that there was a shift from illiquid to liquid assets, income rose, and there was a commensurate increase in consumption as measured by annual expenditure budgets among households that had insurance versus those that didn't. So while we might be a little bit disappointed in the utilization results and the health results, we should be a little bit optimistic about the financial results. And in fact, in the US, all the recent studies have suggested there's consistent understanding of insurance in the United States. The primary impact of insurance in the United States, such as from as measured by the Oregon Health Insurance Experiment, for example, is that not that it improves health, but because insurance is a financial product, improves your financial condition. It provides reduction in risk. And that's exactly what's going on here. A second group, we gave access to we gave them the right to buy RSBY. We call this a public option in the United States, but basically you get to pay the same premium the government does, and then you get access to RSBY. It's a little bit lower cost approach to providing access to health insurance. Looks a little bit like Medicare Part A in the United States. A third group, we gave them the ability to buy, or the right to buy health insurance, RSBY, but we also gave them a cash transfer, an unconditional cash transfer equal to the premium. Just to figure out what the impact would be if there was a budget neutral access to RSBY. And then the last group was a control group. So we did this back in 2013, and we've done several rounds of surveys. So we have results after 12 months, after 18 months, and in fact we're in the middle of doing a survey now that will give us the impact of RSBY after about 4 years. One of the reasons we did this is we knew that sometimes short-term effects and long-term effects can differ for health insurance. One of the concerns people have is that, or expectations people have is that health insurance over time builds up health stock, the stock of health that you have, and the performance of insurance might improve over time. So we did this study, and we looked at a number of different outcomes. We looked at uptake, we looked at, that is to say, uptake into insurance, we looked at utilization, we looked at the impact on a household's health, we looked at an impact on households' finances. And we found effects that are roughly in line with what the literature in the past has found. The literature that I'm referring to here is studies of randomized controlled trials of health insurance programs in other lower and middle income countries. So in terms of uptake, one of the things we found was that we had actually remarkable uptake. When we offered RSBY for purchase, that is to say we made people pay the premium, there was still a 60% uptake into insurance, which is similar to what we saw for BPL populations under RSBY, where it was functionally for free, which is not surprising. APL populations are going to have higher willingness to pay. It's not surprising that they might uptake even when they have to pay at the same rate that below poverty line populations would uptake at zero price. So that was utilization. If you offered APL populations RSBY for free, they actually took it up at an 80% rate. Now it seems a little bit weird that not 100% of the population would take something for free, but if you even study, for example, the history of Medicaid in the United States, uptake of even free programs is difficult to achieve, and so an 80% uptake is quite remarkable, actually. It suggests a program that requires people to show up to enrollment stations and get high uptake. When we looked at utilization, we actually found that utilization was not very high. Consistent with what you're finding in BPL populations for RSBY, as was mentioned earlier. Utilization rate among BPL populations in RSBY was something like 1 to 2%. It varied across districts in Karnataka. We found a utilization rate that was a little bit higher, that was around 4%. However, there was no increase in utilization in most of the groups. The only group that showed a significant improvement in utilization was actually the group that was asked to pay for RSBY. Which is consistent with the literature that suggests that when people are asked to pay for a product, they're more likely to value it and more likely to use it. Although the specific reasons for that we can go into if you'd like. So utilization impacts were not very substantial. Again, I want to stress this is not a unique finding. If you look at studies that were done, for example, in Mexico of Seguro Popular, you look at Cambodia, you look at Nicaragua, you look at Kenya, you also find no changes in utilization. And it's important to understand why that might be. One reason to remember is that it's not as if individuals don't have access to secondary care in the absence of RSBY. They do have access to public hospitals, and although RSBY expanded coverage to include private hospitals, public hospitals may be an adequate safety net. That might explain why there's not an increase in utilization. It is also the case that even without insurance, when people are paying out of pocket, that does not mean they don't have a method to finance healthcare. We do know that there are informal insurance markets in villages, and there is informal credit markets, so money lenders, so that people can get access to healthcare. So there was a dramatic increase in utilization for much of the group, and there might be good reasons for why that's the case. Now I want to turn to health. If there's not going to be a big utilization effect, you wouldn't expect a big health effect, and that's actually what we find, that at the 12-month and 18-month mark, we don't see dramatic differences in health outcomes. There's some statistically insignificant suggestions that people's self-reported health improves, but for specific things like diabetes and heart attacks and the like, we can run through a list. We don't see significant improvements in health. Again, maybe things will differ after 4 years, and so we should keep an open mind, but it's not there. This is consistent with the utilization effect. If there isn't a big change in utilization, you're not going to see a big impact on health. Usually health is associated with utilization, though not 100% all the time. The one thing that we did find that's quite interesting, though, is that in our finance, when we looked at our finance modules, we did a full asset survey of these households. One of the things that we discovered was that people changed their asset allocations. It appears they changed their asset allocations in response to having health insurance. Knowing that you didn't have to have money on hand in order to pay for emergency health care at a hospital meant that you could invest your money separately in a different way. So what would happen when you didn't have health insurance is that you would invest in assets that were liquid, that you could quickly sell, so that you could pay for hospitalization. But once you had health insurance, it appeared that what households did is shift from liquid assets to illiquid assets that were harder to sell. That's an important change because, as it turns out, illiquid assets offer a higher return. And so what we observed in the data is that there was a shift from illiquid to liquid assets, income rose, and there was a commensurate increase in consumption as measured by annual expenditure budgets among households that had insurance versus those that didn't. So while we might be a little bit disappointed in the utilization results and the health results, we should be a little bit optimistic about the financial results. And in fact, in the US, all the recent studies have suggested there's consistent understanding of insurance in the United States. The primary impact of insurance in the United States, such as from as measured by the Oregon Health Insurance Experiment, for example, is that not that it improves health, but because insurance is a financial product, improves your financial condition. It provides reduction in risk. And that's exactly what's going on here. So we do find that RSBYs has not a significant utilization or health impact, but has a financial impact. I think that'll change the way that we think about Ayushman Bharat and the expectations we should have for Ayushman Bharat. But there's a lot that we can learn about some of the failures in RSBY. Maybe during discussion we can talk about that.
Thank you so much for sharing the early results, Professor Malani, and of course the interesting results that he finds that the precautionary savings that households keep in a liquid form in their banks, suddenly they start investing. And it gives us immense hope that if the coverage is 5 lakh rupees instead of 30,000 that was under RSBY, the economic case for providing universal health care becomes even stronger. It's not only just improving the human capital, it is changing the financial portfolio of the households. They're putting money in more illiquid assets potentially for future higher returns. So maybe more income to be generated in the future as a result of Ayushman Bharat.